is a budget hearing conducted by the Committee on Appropriations and Adjudication. Now reconvenes discussions of the fiscal year 2018 executive budget. This afternoon, we are meeting with the Department of Public Health and Social Services to discuss their budget. I have a very short opening statement. I want to preface this budget hearing with the uncertainty the government of Guam faces with regards to potential negative impacts to general fund revenue collections and economic activity as a result of the numerous factors such as the H-2 visa denials, potential tax reforms, and cuts that may erode Guam's revenue base, caps on Section 30 revenues to be collected, etc. With these issues at the top of our mind, the Guam Legislature has a daunting task of ensuring that we provide the funding for the public services the people of Guam want and need. As a brief overview, the Governor's budget, FY 2018 executive budget request of the Department of Public Health and Social Services provides a $98.8 million appropriation, which is $3.4 million less than the 27 authorized level of 102.3. Although the following figure represents a decrease, the government must take a cautious approach given the proposed changes in the pipeline with the recent passage of the American Health Care Act of 2017 by the U.S. House of Representatives. Although significant changes will most likely be made by the U.S. Senate, great uncertainty still exists as the final dollar impact of those federal proposals. With Washington's mercurial environment today, the government must be vigilant to adapt to any of the proposed changes. I would like to focus today's hearing with the department to what we know about these proposals at this time. I want to thank the officials of Public Health and Social Services for being here. I understand from listening to the radio yesterday morning, you rehearsed for a 2-hour presentation, Mr. Bill?
Yes, Mr. Chairman.
Let's proceed.
Thank you very much. Good afternoon, Chairman Cruz.
You might need to move that closer to yourself to get it by better equipment.
Senator Rodriguez, Senator Stevis, Senator Algan, Senator Biscoli, Senator Morrison, Senator Torres. Thank you for giving us the opportunity to make this presentation. I'm going to do some opening remarks, and then our division people will give you specifics on the budget. The reason that we had rehearsed for a 2-hour presentation, we'll try to get it shorter for you, and it's going to depend on the questions that you might have. But we timed it, and we think we've got it down to a little bit less than 2 hours. But it's also it's kind of death by PowerPoint. But I think it's important that some of the new senators see the breadth and scope. As you say, you have a daunting task as policymakers. We have a daunting task. And I think you need to see what our mission goals and strategies are by division, by department. So thank you very much for this opportunity. My name is James Gill, and I'm the Director of the Department of Public Health and Social Services. I have with me as principal presenters, in order of the budget documents that were presented to you early this year, Mr. Tommy Tideway, our Administrative Services Officer, who will speak to the overall budget and specifically about the Division of General Administration, followed by Mr. Tom Nadeau, Chief of the Division of Environmental Health, Dr. Suzanne Kaneshiro, Chief Public Health Officer, Mr. Arthur St. Augustine, Administrator of the Division of Senior Citizens, and Ms. Tess Archangel, Chief of the Division of Public Welfare. I understand you've had our documents well in advance. We're prepared to answer any specific questions you have relative to the budget, but we ask you to allow us to present this PowerPoint presentation to you. I think it's worthwhile for the new members, as I said, to see the vast and overwhelming tasks that have been set before us in serving our people. I can get the page separated. The array of needs and threats to our community comes not only in matters of population health. Every division in some direct or indirect way affects the lives of the people, of every person on Guam. and can have positive impact on the well-being of our people. Currently, we face an alarming increase in non-communicable disease morbidity, such as cardiac disease, cancer, stroke, and diabetes, which now count as the leading causes of death and disability in this island, and are taking the lives of an ever-increasing number of our people. In addition, threats from communicable disease, infectious disease, and vector-borne diseases like dengue fever, Zika, and malaria are looming in the horizon. Multiple drug-resistant tuberculosis is already here and is costing us anywhere from $300,000 to $500,000 per person to treat. XMDR cases may also soon appear with a mortality rate of over 75%. Access to primary care is a challenge due to the meager reimbursements we can provide through our Medicaid and MIP programs. I'm sure you heard enough of that yesterday at the GMH testimony. We also feel that we are generally spending dollars on the wrong end of the spectrum. More should be invested in the population that is not yet at risk for NCDs, and more should be spent on the neglected tropical diseases. The Division of Environmental Health is equally challenged by the mandates it has, which are underfunded. Although there are many environmental health programs that need to be implemented, food safety and mosquito control are the division's main priorities. With over 3,000 establishments that ideally and statutorily require quarterly inspections, current staffing batting numbers prevent us from meeting this need. The newly established Guam Environmental Public Health Lab, commonly referred to as the Mosquito Lab, offers us hope for control of this vector and its potential to transmit diseases to our people and our visitors. The Division of Public Welfare offers hope and support for over 66,000 residents in a variety of programs, from the well-known SNAP program to the not-so-well-known JOBS program. We offer support and protection for the youngest population through our Child Protective Services, which not only seek to prevent physical and mental harm to our children, but also offer services that hopefully can heal families and bring them back together. Dealing with child abuse is the most stressful and demanding task I can imagine. The dedicated staff of BOSA truly are unsung heroes. The Division of Senior Citizens provides services that promote and support our seniors, our manamko, to age gracefully in place. Services range from home and community-based services like adult daycare services to information referral and assistance services to ensure seniors, their families, and or caregivers can make informed decisions as to their health coverage, housing options, long-term support options, as well as to prevent and or address adult abuse. Unfortunately, this day and age, in this island, we're speaking about adult abuse. Yet, on the continuum of care to ensure our seniors are taken care of, we also have to ensure that they are not victims of physical or financial emotional abuse. The reality is our seniors need our support so they can, for as long as possible, age in a home-like community, not in an institution, while safeguarding their assets. I can go on, but I think you know what the story is, and you know that our time is limited. And I appreciate your time, but I'd like you to just take a look at the attachments that I had to this. When we look at typically what has been happening with non-communicable disease, it's a little stick chart, but it's very powerful. And it talks about three cohorts, okay? Youth, adults with NCD risks, and adults with NCDs. Okay? This was the typical picture 10, 15 years ago. The second one shows that at least we've tried to make some inroads into addressing adults with NCD risk and adults with NCDs by making policy changes and doing some health education and doing a little bit more primary health care for diabetes and hypertension. And so we've kind of slowed down the fall off the cliff. But those folks that are at the bottom of the cliff are the ones that we are spending the most dollars on. And the next one shows how much Health and Human Services, just that federal department alone in 1 year, Total spending, 2017 was $1.4 trillion. But out of that, only $4.9 billion was preventive health care. So even they don't get it. But it's also because of the realities of what is happening in our populations. Non-communicable diseases are very expensive to deal with if you don't intervene early. They are, for most part, preventable. We know that routine vaccinations for even HPV, if we could just get people to get to them, would eliminate a lot of cancers. We know that immunization, by and large, prevents a lot of disease. But we also know that diet, exercise, safe environments, the built environment that is user-friendly and exercise-friendly, makes a lot of difference in people's health as they go forward. We have on our Pacific Island Health Officers Association staff a chronic disease epidemiologist, and she travels throughout the region. And somebody from HHS asked her recently, what would be one of the two things that you think would impact the population health status? And she said, after all her years of experience, school lunches, school breakfast. If they just had healthy, nutritious meals. And this is somebody who's making a living measuring people who are not doing very well. And she is aware of the fact that how important nutrition, adequate nutrition, is. And so when we look at this healthcare dollar, we may want to consider as policymakers and also as people who have to implement the policy, moving the dollar somewhere else. You know, I really don't have any, I'm not interested in building an empire here. I mean, if you think the money more of it should go to DOE for physical education and for, better nutrition programs and for a lot of other things, and you say to us, let's do a deep dive, and where can we move programs, where can we eliminate programs? I mean, it might cost jobs, it can be very, very difficult decisions. But I think, as I spoke to you earlier, Mr. Speaker, I'm discouraged. I hate to say that, but when it comes to non-communicable diseases, chronic disease, I'm discouraged. We haven't moved the needle. The only thing that has moved the needle that it offers any hope is the policy decisions that some of you have made on alcohol, access to alcohol, and raising the access to tobacco. We find in the region that that's the only indicator in non-communicable diseases that has had a downtick. Alcohol and tobacco use among youth. And it's because of the policy changes and not about any other interventions. Maybe a little education, okay, but I think we need to spend more on education. So that's where I am with that. Okay? And we still have the dual threat of communicable disease. We don't know, if you're going to ask me what HHS is going to be doing a year from now, I have no idea. And I don't think anybody does. But I think what was submitted to the Senate is not going to be, what comes out. But if it does, then Ms. Archangel has a very difficult job to do because we won't have the Medicaid funds that we plan on. We won't have prevention and public health block grant money. We won't have prevention and public health services programs. Our laboratory and capacity building program, our Zika control programs, all of those will go away. So let us hope that cooler heads will prevail in the Senate. But I think we have to be ready. I think Senator San Nicolas was right with was hitting it right with the bill that he had introduced, talking about continuation of operations and developing budgets and programs that had a 10, 20, and 30% budget reduction scenario. I think that's something that's worthwhile looking at. So if you will allow us, we can begin with our presentation on general administration. Thank you.
Mr. Gillum, can you just explain what XMDR cases are? I don't understand that acronym.
Extreme. Okay, it's multiple drug-resistant cases of TB to such an extent that they're almost untreatable.
Okay, thank you.
Good afternoon. My name is Tommy Tidegree. I'm the Administrative Services Officer for the Department of Public Health and Social Services, and I'm presenting on behalf of the Division of General Administration. Our mission statement at the Department of Public Health and Social Services is to assist the people of Guam in achieving and maintaining their highest levels of independence and self-sufficiency in health and social welfare. Our vision statement: empowered people of healthy mind and body living in a safe environment throughout their lifetime. Next slide. This is an illustration of our organization chart, and the Division of General Administration is one of 5 divisions within the department. The others being the Division of Environmental Health, the Division of Public Health, the Division of Senior Citizens, and the Division of Public Welfare. There are 7 entities within the Division of General Administration, the first being the Director's Office, the next being Management Support Services, the next being Health Professional Licensure Office, followed by Financial Management Section. That's the section I'm in. Supply Section, Facilities and Maintenance Section, and the Systems and Programming Group. This next slide is going to present information with regard to our personnel requests. If you notice from this table reflects our hiring activity from 2011 through 2017. We currently have a total number of 415 individuals that are employed with our department. That's like 59% from where we were in 2011. Just last year, that's 6% more than what we had last fiscal year. This slide represents the breakdown of those 415 individuals, and it shows where those individuals are.
I wanted to add a little bit to that. The 400, we have 415 employees, and over time it looks like we're doing pretty well, recruiting and from where we were. But I took a look at our staffing pattern. I asked the HR people to give me that. 415 employees, but we have 98 that have 25 or more years in service and are in the defined benefit plan. So we can anticipate those people moving out fairly soon. Of the 98, 31 have 30 or more years. Okay, so these are very experienced people, some of them nursing level, and some are physicians. And then of 154 of the 415 have 20 years or more service. So we have to start playing for that continuity of operation. Thank you.
This is the breakdown of where those employees are actually employed. We have the bulk of them, 56%, or 234 of them, within the Division of Public Health, followed by the Division of Public Welfare. They have a total of 123, or 30%. And then the remaining are within the Environmental Health and General Admin and Senior Citizens Division. The next slide kind of portrays the number of retirees that we've had since 2011. If you notice, At this point in 2017, we only show 2, but our experience in the past is a lot of the retirees, if they're going to retire in 2017, they're going to do it at the end of the fiscal year. So that number may end up rising. We have a list of 72 pending recruitment requests as of May 16, and they're either at HR DOA being processed, or else even with our personnel officer department. But we do have a pending list of 72 recruitment requests. Our successes in the division include in 2010 we were 1 in 73 health departments in the nation that received the grant through the CDC's National Public Health Improvement Initiative. And this initiative had 3 primary focus areas: accreditation, readiness, performance management, and quality improvement, fostering collaboration. Between 2010 and 2015, this funding that we received helped us strengthen our infrastructure to support performance management efforts, including human resources, information technology, quality improvement, and performance management. I also want to note that prerequisites for accreditation include a community health assessment, a community health improvement plan, and an organization strategic plan. All of which we've completed. With the community health assessment, we completed it in 2013, and in 2015, we completed both the community health improvement plan and the organizational strategic plan. Other successes include staff training. We continue to provide staff the opportunity to train for training courses that are offered through other government and local government and federal government agencies, nonprofit and private agencies. I want to also include that the procurement training that was mandated through Public Law 32-131, we have a number of 50 staff. We estimate 50 of our staff members have been trained or have completed training on the various modules 1 through 4. We've been awarded World Health Organization funds, and with these funds we were able to establish a Pacific Open Learning Health Net. And we've supported the non-communicable disease programs. We've provided professional development training opportunities, and we continue to provide that professional development training opportunities. With DOI, Department of Interior grant funds that we've been awarded, we've been able to provide for capital improvement projects. These projects include preventive maintenance and minor repairs to our air conditioning units. One thing to note is our building, our facility in Manila is over half a century old, and so we encounter a lot of issues. We've been able to provide with the DOI money, we've been able to renovate and repair our TB laboratory. We were able to purchase a midget mycobacterial detection system. We've been able to purchase supplies for the laboratory, for the TB laboratory. We've been able to repair our roofs. And we continue to conduct the air conditioning system evaluation, testing, and balancing assessments. We've been able to cost save in the area of telephone services as we've assessed all our numbers, and we found that there are quite a good number of lines that we weren't using that we ended up discontinuing. Our challenges, as with all the challenges within the division of general administration, also extends to the other divisions, which includes the recruitment and procurement delays, information technology support not readily available, and then most especially our electric generator at the Manila facility. We're not able to use that generator because of the capacity limitations. We're currently in the process of procuring services to assess load distribution and capacity, and we're doing this in order to appropriately provide for appropriate power transformer, and then also appropriate upgrade to our backup generator. How are we meeting our goals in our strategic plan? We have three priority areas that we listed. The first being develop workforce, the second being modernize IT and support systems, and the third being to improve our organizational structure and processes. With the first priority, we address Mr. Gillen's concern of succession planning, and those are the primary area that under this priority that we're working with, together with workforce development plans, positions needed, what positions do we need, our competencies and certifications, and then cross-training. With priority 2, we are addressing health information technology, resources, the needs assessment, and the IT gaps and issues. With the priority 3, we actually have a quality improvement council in place, and these council members include different staff from the different divisions, and they pretty much meet and they have actually conducted studies and time studies on like procurement and recruitment processes. They'll collect the data, 6 months worth of data, and they conduct an analysis of the data. They compare it against process maps, and then they meet with focus groups to validate the findings, and then all in an effort to prepare a report to include recommendations for improvement. This represents what we were appropriated through Public Law 33-185, and it's excluding the FGIA. This is made up of all local appropriations. We see that 90% of this is coming from general fund, while 8% is coming from the Healthy Futures Fund, and a little bit under 2% from the Division of Environmental Health's Environmental Health Fund and Sanitary Inspection Revolving Fund. This is a picture of our status now, our budget status. We've expended through March 31st 43% of that $67 million. We have outstanding encumbrances in the amount of $7.4 million, or 11%. What we have available to last us through the remaining year is 46% of that $67 million, and that amounts to $31 million. Thanks. this is our proposed budget, excluding the FGIA, $68.191 million, 89% being proposed from general funds. Now this 89% includes general funds for MIP, general funds for cancer screening treatment, with 8% coming from Healthy Futures Fund. This provides for mostly the Division of Public Health and also for $200,000 for the cancer screening and treatment. And the remaining 2% coming from the Environmental Health Fund and the Sanitary Inspection Revolving Fund. This next slide shows how we shows that 60 million in the general fund that we talked about, that 90% of that 68 million. This is how it's broken down in object categories. And if you see that, for the most, that dark blue part of the circle there, the pie, that's 58%, which is earmarked for miscellaneous, and that's really your payments and your your local match requirement for the FGIA. And the next of the larger ones are the contractual services being 22%, and then personnel being 14%. This next slide shows the breakdown of that general fund request, or the proposal, the proposed amount that we're requesting from the general fund. When we divide it, or we show it by how it's going to be distributed by division, we see that the Division of Public Welfare is proposing 71% of that $60 million, while the senior citizens proposing to budget 15%. And with the remaining 14%, it's scattered between the Environmental Health, Division of General Administration, and the Division of Public Health. This is a breakdown of the object categories in the Healthy Futures Fund. You see that the blue, the red, and the green there, that's all personnel. Most of 95% of this is going into personnel. The $5.9 million is top heavy with the personnel costs, and you got to remember that most of this money is going into the Division of Public Health, and it provides for the salaries of physician specialists, community health nurses, and even licensed practicum nurses. And we show a breakdown. This next slide shows a breakdown of where exactly it goes, which division receives that Healthy Futures Fund money. You notice that, with the exception of, it's that orange piece of the slice, that orange slice there, that $200,000 is earmarked for the Division of Public Welfare to provide for cancer screening and treatment. The remaining of that $5.9 million is divvied up between the Bureau of Primary Care Services, the Bureau of Community Health Services, the Bureau of Family Health and Nursing Services, and the Chief Public Health Office, all within the Division of Public Health. With the 2% of that $68 million, we're requesting that it be earmarked for environmental health, the Division of Environmental Health, through the Environmental Health Fund and the Sanitary Inspection Revolving Fund. I've been able to, what you see there is a breakdown as by object categories. for each of those funds. That's pretty much my presentation for you.
If I may have the technician in the back put up the environmental health presentation, please. Oh, thank you. Thank you. So good afternoon, everybody. My name is Tom Nadeau. I am the Chief Environmental Public Health Officer with the Division of Environmental Health. It is our mission to serve and protect the people of Guam from environmental hazards and drug diversion through education and the implementation of governing laws designed to prevent injuries, diseases, disabilities, and death. And above you, or above me, we are presenting the budget request for environmental health. We are respectfully requesting an amount of $2.3 million for personnel and operation for fiscal year 2018, which represents approximately 2% of the total budget requested by the department. Furthermore, we're requesting for possible carryover of 2017 lapses similar to the provision that was made for this fiscal year. This is the very simplified organization chart of Division of Environmental Health. We have 3 bureaus. However, with the recent construction of the Guam Environmental Public Health Lab, we may be realigning our division to add another section, or bureau within our division. Currently, we have 28 funded positions, and within the 28, we have 21 that are filled, and 7 that are still pending recruitment. And we are optimistic that we'll have a complete full-time employees by end of this fiscal year. There are 43 mandates for Division of Environmental Health within our health code. And we are known primarily for our enforcement of sanitation of health regular establishments, such as restaurants, retail facilities, childcare facilities, tattoo shops, dry cleaners, therapeutic massage, the other kind of massage, cemetery, mortuary, swimming pools, hotels, temporary workforce housing, schools, and beauty salons. However, we also investigate public nuisance complaints that relate to such as complaints about rodents, harbor site, mosquito breeding sites, littering, trash, foul odor, anything which constitute a unsanitary condition in our community. But of course, we do more than that, as our mandates include radiological health, regulating retail hazardous substances, animal vector control, such as livestock and poultry, rodents, and mosquitoes, as well as regulating consumer commodities for food, drug, cosmetics, as well as solid waste and wastewater respective to residential garbage and chemical toilets. Oh yes, we also are responsible for enforcing indoor smoking at regulated facilities. There is another statute, another mandate that we have in our authority, and that falls under not the health code, but the crime code. It is the Uniform Controlled Substance Act. We regulate the manufacture, distribution, and dispensing of pharmaceutical controlled substances, such as opioids and sedatives, to prevent its diversion into illicit activities. We also monitor the prescribing and dispensing of controlled drugs to assist healthcare professionals and monitor the patients in their acquisition of controlled drugs, especially in the prevention of misuse and abuse. We have 5 funding sources currently. We have the Environmental Health Fund, which is revenues derived from the issuance of health certificates and sanitary permits. We have the Sanitary Inspection Revolving Fund for the registration of temporary alien laborers. We have the Controlled Substance Diversion Fund, which originates from the issuance of Guam Controlled Substance Registration. And we have the federal grant from U.S. Department of Justice for our prescription monitoring program. Because the DOJ grant is a competitive grant, we're not assured funding, so it's not a reliable source of income, reliable source of funding for us. And also our Controlled Substance Diversion Fund, we
generate less than $80,000 a year. So bulk of our funding is from the three: the Environmental Health Fund, the General Fund, and the Sanitary Inspection Revolving Fund. So essentially, we're primarily a locally funded division. The graph presented to you represents appropriation of three funds in the past 3 years. The red is the Environmental Health line, blue is the General Fund, and green is the Sanitary Inspection Revolving Fund. As you can see, the division has become increasingly more reliant on the Environmental Health Fund compared to other funding sources over the years. In the following graph, it shows environmental health has been generating approximately $1.2 million in the past 3 years, and we're tracking the same amount for this fiscal year. The SIRF has been the Sanitary Inspection Revolving Fund has been fairly stable since its inception in 2011. However, we've seen a significant reduction in revenue this fiscal year as there have been less migrant laborers being registered, which we assume is from the H-2 visa denial that's been going on. In the following chart, the blue line and its corresponding blue number represents health certificate that's been issued in the past 13 years, which has been about 35,000. Health certificates are issued to employees working at health-regulated establishments. The red line and its corresponding red number represent the revenues generated for the same period, which has been approximately 300,000. Okay, the sanitary permit. This graph is regarding similar in sense, except it's for sanitary permit issuance and revenue generation. The blue line represents the issuance, the red line for the revenue. We issue approximately 3,000 annually of sanitary permits, and we generated close to 900,000 every year. Now, of the several mandates of the Division of Environmental Health, there are two programs in particular, which, like the directors mentioned, that we invest a lot of resources into, and that is the mosquito control program. Guam has been extremely fortunate that we are free of endemic mosquito-borne diseases. Reported cases have been few and far apart, and all have been imported cases. We are working to prevent the introduction and spread of mosquito-borne diseases such as dengue, malaria, chikungunya, and of course Zika. If a mosquito-borne disease was to become established on island, its impact to our health and economy would be substantial. The second program a lot of our focus has been on food safety program. Because we all eat, we're all at risk for foodborne illness. And most of the sanitary permits that we issue has been for food-related establishments. In respect to the mosquito control program, we were very fortunate to receive the United States Department of Interior CIP grant several years ago for the construction of the Guam Environmental Public Health Lab, affectionately known or otherwise known as the Mosquito Lab. The building was finally constructed last year, and we are just now making preparations to move in. This lab will literally and figuratively be the foundation which our program will be built upon. And it is our goal to someday not just be in the islands lab, but also the regional lab. Okay. As the slides will show you, we've already procured and installed most major fixed assets, and just a matter of just moving into it and starting our program. In addition, we receive assistance from PIHOA, which is Pacific Island Health Officers Association, and CDC in the acquisition of a private consultant who has been assisting us in developing our lab capacity. We've also received help from the Zika response team in improving our protocols and our gathering baseline mosquito data. These are just some photos of some of the field activities we perform in collecting and identifying mosquitoes. In the future, we'll be testing for mosquitoes to determine the presence of pathogens. We've also been collaborating with the military, specifically the U.S. Naval Hospital. They've assisted us in identifying and testing our mosquito samples. In addition, our staff have been obtaining training, or will be obtaining training through the support of World Health Organization, PIHOA, and CDC. Going back to the food safety program, we have prioritized the inspection of food facilities over other permitted establishments, especially when you consider that over 75% of all sanitary permits that are issued are for food facilities. And our inspections reflect just that. In the past 6 years, 66% of all inspections have been on food facilities. And after a decade of promoting the adoption of the Guam Food Code, which did accomplish, and the subsequent 2 years of training, educating the industry on the code's requirements, we're finally implementing and enforcing the code. In addition, we have also directing our resources into inspecting temporary events that has been occurring frequently on island. And as the next graph shows, there has been significant increases in temporary food establishments. TFSEs, otherwise known as, are of particular concern in respect to food safety, as compliance tend to become lax due to the limited infrastructure and resources available on site. From fiscal year 2014-2015, as shown, the number of sent to permit actually increased by 14-fold, and the following year after that, it increased by 55%. Thus, my staff is conducting more inspections on weekends and in evenings. Our Guam Environment Public Health Lab is primarily a mosquito lab. However, we also have established a room for our food screening lab to conduct preliminary tests of food and environmental samples for pathogens. Just like the mosquito lab, we've already purchased many of the required instruments. In addition, we've been receiving technical assistance from the U.S. Food and Drug Administration. And with the construction of the lab, we plan to become less reliant of our outside partners and become more independent in responding to outbreaks. Major challenges, like any division, we have our share. Some of the challenges include the number of compliance inspections we do. The law mandates that we do 4 inspections for every establishment every year. Because we have around 3,000 establishments, that equates to 12,000 inspections that we are mandated to do every year. And as the graph shows, last year we were able to do 1,045, which is an increase of 87% from the previous years. However, if you look at the exact numbers that we were supposed to do every year, they only represent 10% of the inspections. As a result, we've been concentrating on educating and training the industry, implementing risk-based inspections that dictate which establishments gets prioritized, the frequency of such inspections, and the focus of our inspections. We have other environmental health programs that have not received the same attention as our 2 priority programs, such as our radiological health program, consumer commodities program, and a few others. As a result, these programs have become reactive rather than proactive, which is a hallmark of all environmental health programs. We just simply do not have the resources to do them all, but we do our best. In addition, nearly all of our 40 mandates requires the adoption of rules and regulations, and some of them go back 30 years, so we're constantly updating our regulations to ensure that we stay abreast of the needs of the community. And if you recall our environmental health lab reference and the org chart, currently we do not have any laboratorians or any specific position dedicated to the lab, so we'll be reassigning existing staff and increasing their duties and responsibilities. We understand this is additional responsibility and burden to the staff, but we are committed to the operation of this lab because we do understand the significance and its importance. But we do have a sustainability plan, which I'll get to in a minute. So for the major goals of next fiscal year, for the food safety program, we'll continue to build the foundation of the screening lab. With the anticipated recruitment of 4 vacant inspector positions this year, we will be looking to increase our inspection the following year. For the mosquito program, we will be establishing the Mosquito Advisory Council, which will be comprised of community stakeholders to address mosquito control. And we'll be performing routine active surveillance of mosquitoes. DEH will be taking over the health certificate training course on food safety from Guam Community College. DEH will be utilizing its new training room located in our lab as the venue site for such training, and the course will be taught by an existing health educator. As a result, we are projecting an increase of additional $220,000 into the Environmental Health Fund, which should assist us in maintaining our lab operation. And with that, I'd like to thank you, everyone, for listening, giving the opportunity to present the status of our environmental health program, division. Thank you.
Good afternoon. My name is Dr. Suzanne Kaneshiro. I'm the Chief Public Health Officer in the Department of Public Health, and I'm speaking on behalf of the Division of Public Health. Okay, the mission of the Division of Public Health is to preserve, promote, and improve the health and well-being of populations, communities, and individuals through prevention, education, surveillance, treatment, and regulations. The vision of the Division of Public Health is empowered people of healthy mind and body living in a safe environment through their lifetime. The Division of Public Health is made up of 5 bureaus, plus the Chief Public Health Office. As you can see, it's very busy. We have over 200 employees in my division. Okay. Under the Chief Public Health Office, we have the Office of Vital Statistics, which issues birth, death, and marriage certificates, plus marriage licenses. We also have the dental program, and now we have also the medical marijuana program. The Bureau of Communicable Disease Control includes the Guam Public Health Laboratory, the immunization program, radiological services, pharmacy services, public health emergency preparedness program, the STD/HIV program, and the TB program. The Bureau of Community Health Services includes the Behavioral Risk Factor Surveillance System, the Breast and Cervical Cancer Early Detection Program, the Comprehensive Cancer Control Program, the Diabetes Control and Prevention Program, Medical Social Services, NCD Consortium, the Office of Minority Health, and the Tobacco Control and Prevention Program. In the Bureau of Family Health and Nursing Services, we have the Children with Special Health Care Needs Program, the Family Planning Program, the Maternal and Child Health Program, the Medical Records, Nursing Services, Project Visita y Familia, which is the Early Home Visiting Program, Project Carina, which is the Child Mental Health Program. Under the Bureau of Nutrition Services, we have the Farmers Market Nutrition Program, General Nutrition Services, Loving Support Breastfeeding Peer Counseling Program, the Preventive Health and Health Services Block Grant, and the WIC program. And finally, we also have the Bureau of Primary Care Services, which has the community health centers, one in the north in Dededo and one in the south in Inarajan. So some of our successes is the extended outreach clinics we've had since 2009 at the community health centers. The community health center staff, which includes physicians, nurses, and support staff, go out to the villages where low-income and high-risk families reside and conduct a medical clinic to those who are unable to go to the community health centers. We also have community partners joining us, including the WIC program, the STD/HIV program, the Guam Head Start, Guam Early Hearing Detection and Intervention, Guam Early Intervention System, and the Guam Legal Services. So we provide this at the village level. We offer a full range of services: women's health, including prenatal and postpartum care, family planning, cancer screenings. We also have child health services, which include well baby checks, immunizations, physicals, and fluoride varnish. We also offer chronic care, blood pressure, blood glucose screenings, pregnancy tests, hearing tests, and health education. The clinics are conducted 6 to 8 times a year, and we see about 100 to 200 patients per outreach. Some of the locations we've gone to is the Agate Mayor's Office, Agate Calchao Subdivision, Aspen Community Center, Astumo Community Center, Astumo Gym, Jigo Gym, Gil Baza, Gil Breeze, and Mariso Senior Citizen Center. So these are areas where there are low-income families reside. We average about 1,000 patients a year. We average about 1,000 patients a year in these extended clinics. So last year we saw 1,322 patients. Okay, another success is our NCD consortium. It's made up of representatives from government agencies, not-for-profit organizations, and private sector. We have about 200 plus members in the organization. It was established to reduce the burden of NCDs, such as heart disease, cancer, diabetes, and obesity. The program addresses smoking, nutrition, alcohol, physical activity, and obesity. Okay, some of the NCD activities is we help getting laws passed, including the Nana Yan Patun Act, which allows women to breastfeed or express breast milk in any location, both private and public. This was passed in 2013. We have no smoking in bars, which was passed in 2016. And now we also have that only adults aged 21 and older will be allowed to legally purchase and use tobacco and e-cigarettes of Guam, effective January 1st, 2018. Another success is our telemedicine with the Good Samaritan Hospital. Community health center patients with Medicaid are able to consult with physicians at Good Samaritan Hospital, specializing in dermatology and rheumatology. These are specialties that are not found on Guam. Patients no longer have to travel off-island for these types of care. Since 2016, 19 patients have been seen, and we currently have 64 patients on the waiting list. We offer 1 to 2 sessions a month. Each session is about 30 to 60 minutes per session, and we will see about 4 patients per session. Okay, another success is our project Visisa y Familia, the maternal, infant, and early childhood home visiting program. It is an evidence-based home visiting service for pregnant women and families with young children at high risk of poor outcomes. So far, we've served 260 children and adults in the program. Last year, Project Visita received the National Accreditation from Healthy Families America, the signature program of Prevent Child Abuse America. Its accreditation is good for 5 years. Guam is the first U.S. territory to get this prestigious distinction. We met the 12 critical elements of the program. Another success is our WIC Health and Nutrition Delivery Systems, or HANS, consortium. This is a partnership which shares technical knowledge and fiscal resources to operate a fully integrated automation system among 5 state WIC agencies. HANS partners have been awarded an electronic benefits transfer contract for the electronic issuance of WIC food benefits to be completed by 2019. Another success is our Guam Public Health Lab. They obtained the CLIA certification. Labs must be CLIA certified before they can accept human samples for diagnostic testing. Able to perform dengue, chikungunya, and Zika testing on clinical serum specimens. We no longer have to send these specimens off-island to get tested. Clinicians can now treat patients on a more timely basis. Okay, one of our major challenges is the tuberculosis problem. The number of TB cases on Guam are rising. From January 2009 to July 2016, there were 560 cases of TB on Guam. Most of the cases are imported from countries like the Philippines and FSM. As of April 2017, we have 16 active TB cases and 150 contacts under treatment at Central Public Health. As you can see, the number of TB cases have been increasing since 2007. Okay, the number of TB cases reported from January 2009 to July 2016 Most of the cases come from the FSM, which 1,186, followed by the Republic of Marshall Islands with 1,151. And Guam comes in third with 560. Most of the TB cases are imported. Most of them are actually imported from the Philippines and not the FSM as people probably think of. And the next is Guam, so it's on the island. Guam's location in the Western Pacific puts it at a high risk of TB exposure, especially MDR-TB and XDR-TB. MDR-TB and XDR-TB cases are present in the Pacific region, Philippines, Asia, and Russia. TB patients are becoming more drug resistant. The multi-drug resistant TB, or the MDR-TB, is a form of tuberculosis infection caused by bacteria that are resistant to treatment with at least two of the most powerful first-line anti-TB medication drugs, isoniazid and rifampin. There are currently 5 patients who are classified as multi-drug resistant patients. Okay, so the number of MDR cases, so far in 2016 we have 7. So it's been rising over the years. Extreme drug-resistant TB, or XDR-TB, is a rare type of multi-drug resistant TB that is resistant to isoniazid and rifampin, plus any fluoroquinolone, and at least one of 3 injectable second-line drugs. There are currently 1 confirmed pre-XDR case on Guam and 1 possible pre-XDR case. Why is XDR-TB a serious problem? Because XDR-TB is resistant to the most potent TB drugs, the remaining treatment options are less effective, have more side effects, and are more expensive. XDR-TB is of special concern for persons with HIV infection or other conditions that can weaken the immune system. These persons are more likely to develop TB disease once they are infected, and also have a higher risk of death once they develop TB disease. Okay, so non-MDR case takes about 6 to 9 months to treat and costs $17,000. For an MDR case, which is 20 to 26 months, it's $134,000. Okay, some of our challenges: paying for the TB medication. In FY2016, we paid out $185,000. And so far in FY 2017, we've paid out $186,000, which is only 6 months in the year. There's no proper isolation room at the Central Public Health to treat these patients. We also have no facility to isolate patients with active TB. So this is a problem, especially with the homeless population and with non-compliant patients. Okay, some of our other challenges: the Office of Vital Statistics no longer has an electronic birth and death registration system supported by the National Association for Public Health Statistics and Information System. The registration system is supposed to enable vital statistics to register and administer vital records securely, accurately, and quickly. Because there's no electronic registration system at OVS to enter birth and death records, the staff must manually enter the records, causing a delay in issuing certificates to clients. In 2016, 3,441 birth certificates, 1,024 death certificates, and 1,288 marriage certificates were issued. The Office of Vital Statistics are trying to find a registration system that's within its budget and easy to maintain. Other challenges: the WIC program has inadequate facilities to service its caseload. The WIC Manila Clinic has been uninhabitable since the end of FY 2016. Overall, WIC caseload has fallen from an average of around 7,200 clients in FY 2016 to approximately 6,600 clients presently. Other challenges: we have a shortage of physicians, nurses, and dietitians in the department. One of the main reasons is because of the low salaries we offer. Recruitment is very slow. Procurement takes a long time to do, and future funding is undetermined. Are we meeting goals in our strategic plan? The Guam Comprehensive Cancer Program is fairly successful in meeting its objectives in its work plan and meeting the objectives of the Guam Cancer Control Plan 2012-2017. From the 26 objectives in the Cancer Control Plan, 46% have been met, 31% are ongoing, 8% have not been started, and 15% are not met. If I had adequate staffing, then I could provide medical and dental services to more uninsured and underinsured patients and educate the community on the importance of living a healthy lifestyle, proper nutrition, regular exercise, safe sex, avoiding tobacco, and drinking in moderation. And this would result in more people being healthy and living longer. Thank you.
Can we get the presentation for the Division of Senior Citizens, please? Thank you very much. Mr. Speaker, Speaker Cruz, Secretary Lee, Senator Nelson, Senator Torres, Senator Morrison, Senator Agen, Senator Stavis, Senator Rodriguez, and Senator Munya. To the Committee on Appropriations and Adjudication, I am Arthur San Agustin. I'm the Administrator of the Division of Senior Citizens, and I will walk you through our budget briefing this afternoon. The Division's mission is to plan, coordinate, implement, and evaluate programs and services to identify and leverage all possible resources towards promoting, maintaining, and protecting the total well-being of older persons, while safeguarding their dignity, integrity, independence, values, and cultures. In terms of our division's organization, as the administrator of the division, I report to the Deputy Director and the Director, Deputy Director Casil, and Director Gillen. But within the division, I have a management analyst on 4 bureaus: the Bureau of Administrative Support, the Bureau of Adult Protective Services, Bureau of Community Support, Bureau of Program Administration and Development. Their key functions by Bureau for the Adult Protective Services is really the protection and advocacy of our elderly and our adults with disability, ages 18 through 59. It's really to address and educate our community and protect and raise awareness in our community of this social ill. The Bureau of Community Support is really the information referral and assistance arm of the Division of Senior Citizens. This is really the bureau within our division that provides information to our seniors, their families, their caregivers, and anyone really working with our seniors to access services in our community to help them make informed decisions. And this is really, like I said earlier, it's our marketing arm, knowing what's in the community in terms of resources and options. The next bureau is the Bureau of Program Administration and Development, and this is our contract component within the Division of Senior Citizens. And they look for contract compliance to ensure that our home and community-based services are providing the services as contracted for. They also look at how they can develop and or identify or to improve and or expand the program services on contract. The Bureau of Administrative Support, really, the name as it speaks for itself, it's the arm within the division that provides administrative support for all members of the Division of Senior Citizens. And when I say all members, I'm talking the 10 members that we have today. When authorized for FY17, we have 19. We have 9 classified, 1 that is unclassified. We have 9 on recruitment status. Of the 9, 6 are actively being recruited, as echoed earlier by my colleague. It's anywhere between an interview, waiting for a list from the Department of Administration to conduct the interview. I was just recently advised that we offered an administrative officer position to one of the applicants and she declined. So we will go back and do the interview again. But we will also be moving forward with the 3 pending recruitments in hopes of that we would have all 19 individuals for the Division of Senior Citizens on board before the end of FY17. In terms of our request before you for 2018, this is combining local and federal dollars. It's $12,193,588. Our federal dollars that we expect or anticipate to receive is 2.9. Our local funds is 9.2. I broke this down into 3 key categories: contractual, personnel, and operations. And contractual, it's $10 million or 88% of the division's budget. Personnel is 1.2 or 10%, and operations at 248 or 2%. Now, these funds under contractual 88% of our budget is really to ensure the continuation of these 10 services that is listed here on this PowerPoint presentation. They range from adult daycare of 3 sites, case management, in-home services, legal assistance services, senior center operations, transportation services, nutrition services, of which there are 2 components, congregate and home delivered, as well as our preventive health and our National Family Caregiver Support Program. We have unduplicated counts for 15 and 16, those service years or fiscal years, with 2016 at 3,453 unduplicated. And I just want to take a pause here to explain that, or to share with the committee that a senior, this is the unduplicated count, but a senior who accesses services may start with case management and then be authorized to receive adult daycare services, and while adult daycare services will also be receiving a meal at that program site. So therefore, that senior is actually going to be counted individually at each site. But this is the unduplicated count. Total seniors registered on our registry of all contracted providers. Now, the next slide is really, again, our maintenance of our home and community-based services. And I really wanted to share with the committee is how we capture the units of service. And the unit of service is defined by our granting agency. So if you are attending any of our 3 adult daycare centers, the program will count the number of hours each participant is at those centers. So for FY16, we had 165,180 hours of adult daycare services provided to those in attendance, and it was 148 persons served in 2016. We also provided the data for 2017 up through February 28, 2017. And so as you go through the list, you'll see the manner in which units of services is captured, and that's on the green side of the table. There's hours, and then there's one-way trips. And one-way trips is for our transportation services. And then senior center operations is captured by participation. And so that really would be more like an encounter, because we don't have 325,000 seniors living on Guam. So that is a repeated count. That's an encounter count of participation. Moving on, and again, more home and community-based services is our nutrition program. We have congregate and home delivered. And units are captured by the meal served. So there were 547,975,000 meals served for both congregate and home delivered in 2016. And as of February 28, 2017, we have served through our contracted provider, our vendor, 227,463 meals for congregate and home delivered. Now, for congregate, this program provides meals Monday through Friday, except on weekends and holidays. But for home delivered, it's Monday through Sunday, except on 10 holidays. And this is in compliance with Public Law 26-111 that requires service contract agreements to provide 10 days of holiday for the program. And that's how we understand it. And so there are 10 days within the year that meals are not provided. But I also want to pause and thank the support from the past and the current administration for assisting the Division of Senior Citizens make the Saturday and Sunday a reality, but we also want to ask for your continued support of this service for Saturday and Sunday. In terms of the other part of our job, which, as the director noted, the social ill of abuse against our elderly and adults with disability, I wanted to just provide you some statistics, really to give you a sense of what we're dealing with. If you go through this table from 14 all the way through 17, there really are 3 types of abuse that have been reported in different ranking orders for each respective year, the ranking order being 1, 2, or 3, but they really repeat themselves with neglect, financial property exploitation, and emotional psychological abuse. And so this is the work that our Bureau of Adult Protective Services social workers attend to on a weekly, daily, yearly basis. The other arm of the division is our information referral and assistance, which is really the marketing arm. And one of the key strengths of this bureau within the division is our volunteer program. The bureau currently right now is staffed with a program coordinator 4 and 2 program coordinator 3s. Of the 2 program coordinator 3s, one actually is on active recruitment. Yeah, we're waiting on the list from DOA to do the actual interview. So we really have a staff of 2. Without the volunteers, we couldn't achieve the work that we've done in Medicare counseling and assisting our Medicare beneficiaries navigate through the Medicare system. And their contributions to date of April 7, 2017 has a value of $95,577.45. In addition to those components, we also have a No Wrong Door initiative. And the No Wrong Door initiative really, in a simplified sense, is the Division of Senior Citizens working with the Division of Public Welfare of our Department, Public Health and Social Services, the Department of Integrated Services for Individuals with Disabilities, and Guam Behavioral Health and Wellness Center to streamline the access of services. So many of us have heard many stories about going door to door, agency to agency for services. The No Wrong Door initiative aims to minimize, if not ideally speaking, reduce or decrease or eliminate the need for a person to go to so many different doors just for services. We also received a grant. It's from the Department of Justice, Office of Violence Against Women and Abuse in Later Life. And this is really enhanced training and services grant. And this is looking at anything from dating violence, sexual assault, stalking. And this population is 50 years and older. But when you really look at it, what's going to happen, looking at the key agencies that are partners of this grant initiative, with the AG's office, prosecution division, the judges, law enforcement, our Guam Police Department, the Guam Coalition Against Sexual Assault and Family Violence, Catholic Social Service, who operates the Elite Shelter, and the Division of Senior Citizens, as well as the Governor's Federal Programs Office, is we're building local capacity. We're building local capacity in a concerted way so that when we respond to cases of abuse against an elder, that it's done in a seemingly seamless manner so that it is not a repeated process of asking the same questions over, and we're all singing really off on the same page. And of course, May is Senior Citizens Month, so this is the month we're in, and we're here before you asking for money and continuation of our services through this budget process. And it's really an opportunity for us here in Guam, throughout the nation, to recognize the countless contributions our seniors have given to our community here in Guam in the past, today, and tomorrow. Our annual celebration this year has a host of activities, starting with Wega Manamko, proclamation signing, the Conference on Aging, our Frail Elderly Mass, our May crowning, our centenarian celebration, which we just completed yesterday, and we honored our centenarians here in Guam, of which we had 8 honorees. And next week we'll be celebrating the legislative reception. What I'd like to offer as an idea and a suggestion is that if you would, as a body, amend Public Law 14139, which was acted on August 28, 1978, which created the Division of Senior Citizens. This is not necessarily a novel idea by no stretch of the imagination. It actually exists in the Department of Integrated Services for Individuals with Disabilities. They have a law in place, Public Law 2416, Chapter 41, Article 1, Section 44103, and it goes on to read that district can accept grants, gifts, contributions, and appropriations. Now, for the Division of Senior Citizens, we know that many of our vendors are for-profit or they may be non-profit. We're not wanting to compete with our vendors who are out there reaching out into the community for support of their operations. What we're asking is it's very specific to Senior Citizens Month. What we're finding are there are people who have approached the division and are asking to help out in the celebration. We have a bakery that has, again, time and time again, donated the celebration cake for this event. We have flower shops coming forth, private people coming forth saying, how can I help with the Senior Citizens Month celebration? Of course, one of the most appealing events is our centenarian, because it's a birthday party for Guam centenarians. So we just need something for your consideration if that is at all possible. Now our challenges. Just like my colleagues at the department, one of our challenges is that really there's a concept of level funding, and that has existed time and time again. What really that does for us in the division is it really doesn't give us any room to respond to growth, program changes, and the needs of our seniors. If you've heard in the past that we extended services in the adult daycare program on Saturdays, that was done because through the program, they realized a lapse in personnel. They basically had vacancies. They calculated the value of the vacancies and requested the division and the department to allow them to take those dollars and offer Saturday services. So it really only happens towards the tail end of a contract. We don't have funds that we could say, well, we want to extend the hours on Saturday. And that's why earlier I was saying I really am grateful to the current administration, because they made Saturday and Sunday a reality for our seniors who need the meals at home. And so they're really, that annual funding, it caps us and it keeps us pretty much maintaining services. But if that's what we can get, then that would be of great help to be able to continue services as well. We have a legal wait list of 274 because of our staff size right now, we have limited Medicare counseling days, and we are a non-income generating division. Our services are viewed and are classified as entitlement programs, so we do not charge for our service. Another challenge is that, of course, because we're short-staffed, we do also need to review and update the adult daycare rules and regulations. I've already mentioned staffing and recruitment. And on the last point on this slide, the continuous shifting of work assignments to address critical program matters. Because we're short-staffed, if there's a complaint on any of the programs, we respond to that. And I remember, I believe it was my colleague Nadeau who said we're really being reactive and not proactive. So we really want to move ourselves eventually to the where we can be proactive and not reactive. So our social workers do it all. Unlike other bureaus within our department, they do intake, investigation, aftercare, outreach, education, prevention, and they also serve as an ombudsman. Now, this is something I'd like to toss off for consideration and offer for your consideration as an incentive pay for people within our division, and definitely a policy you can extend beyond the division for when employees actually are carrying more. What has not actually come to pass is that how many cases can a social worker truly carry? How many cases, how many programs can program coordinators also carry before management is actually having to deal with that issue that we're carrying too many cases? Let me give you an example. In our Bureau of Program Administration and Development, I have 2 program coordinator 3s on staff right now. They have 10 contracts to manage. And I really would like them to do more monitoring because it's necessary and critical to ensure operations. I really want them to read up on literature so we can look for best practice models and see how we can be more effective and efficient. But we're managing 5 contracts per program coordinator, and that's just not going to happen right now. So that's just something to consider. Now, in terms of access to the division, for our services, you can definitely come to the division. And we've got our Bureau of Community Support, which is our marketing arm. We've got the Bureau of Adult Protective Services. Even if you are making a referral for protective services, if the intake worker, social worker, also identifies a need for supportive services, they will make a referral for that. They will initiate that referral. And also our Program Administration and Development. The contract staff, if and when working on a situation, identify that a senior, a family member needs assistance, they too will initiate referral. So access, I don't believe it's a big challenge in terms of reaching out to us. All of our contracted providers also is an access point, as well as our 12 senior citizen centers. They're all access points for services. So on that note, I want to thank you all for your time on the presentation of the Division of Senior Citizens, Cesar Masi.
Thank you for your indulgence. One more.
Good afternoon, Senators. I'll be quick. Okay, I'll try to be quick. My name is Maria Teresa Archangel, and I am the Division of Public Welfare Chief Administrator. Our division provides assistance to low-income individuals and families. And our division's mission is to promote positive social conditions that contribute toward the attainment of the highest social well-being of the economically and socially disadvantaged populations on Guam. By developing an efficient and effective delivery system of services to eligible clients, by determining eligibility of applicants, and by administering payments and various social services to remove social barriers which prevent persons from obtaining, maintaining the basic necessities of life. Okay. The next slide shows the organizational chart of the division. I do answer to our director and deputy director, and our division is comprised of 4 bureaus, which includes Bureau of Economic Security, which administers the eligibility determination of the Supplemental Nutrition Program, formerly known as food stamp. SNAP is 50% federal and 50% locally funded as far as administration is concerned, but the benefits of SNAP is 100% federal. Then we have the cash assistance program. Under the cash assistance program, we have the temporary assistance to needy families. We have the old age assistance, aid to the blind, aid to permanently and totally disabled, and general assistance. TANF is 100% federally funded, while the aid to the blind, aid to permanently disabled, and the old age assistance is 75% federally funded, and GA, or general assistance, is 100% local. The Child Care Development Fund supports working families with low income by providing affordable and quality early child care and after-school program. The Medicaid Assistance Program, as well as the Medically Indigent Program, provide medical assistance to low-income individuals. Medicaid has different federal medical assistance percentage. As a result of ACA, we receive an increase of 5% federal medical assistance percentage, so it's now 55-45. And as a result of ACA also, we increase the number of eligibles under the Medicaid program by including the childless adult, so thereby transferring our MIP clients to the Medicaid program to alleviate the shortfall of the MIP. The Medically Indigent program is, of course, through Public Law 2730, is 100% locally funded. Medicaid and MIP benefits and administration is being done by Bureau of Healthcare Financing Administration. And Bureau of Economic Security administers also the SNAP education program, which started in 2014 at $37,000. It increases yearly, and for this year we have $171,824 funding for SNAP Ed. The next bureau is Bureau of Healthcare Financing Administration, which administers the benefits coordination of Medicaid, Children's Health Insurance Program, Medically Indigent Program, Enhanced Allotment Plan, and Health Information Technology. Medicaid, as you know, is federally funded, 55%. Children's Health Insurance Program is an expansion of Medicaid. Currently, as a result of MACRA, or Medicare Access to Pre-Authorization Act, our federal medical assistance percentage went up to 91.5 as compared to previous years. So as you know, the local match is only 8.5. Then the Enhanced Allotment Plan as a result of Medicare Modernization Act of 2003. The federal medical assistance percentage is also 55%. And then the HIT provides incentive payment to providers who adopt, implement, or update the certified EHR. We have been paying some of our providers and even the hospitals here on island. The Bureau of Management Support administers Child Care Development Fund. They also administers the JOBS program and the SNAP Employment and Training Program. Basically, this provides training and education as well as to assist them on their employment. They conduct SNAP quality control, also fraud investigation and collections, and they also oversee the SNAP program information monitoring and management evaluation. And they also do fair hearing coordination. The last bureau is Bureau of Social Services Administration, which administers Title 20 of the Social Security Act, foster care and adoption, child protective services, and home evaluation and placement services. With that, I would like to also present the successes of each bureau. For Bureau of Economic Security, as you can see, they were able to process 66,231 welfare program applications in FY 2016 with 36 employees. They issued a combined total of 110.7 million food and cash assistance benefits to 55,716 SNAP and 6,632 CAP eligibles. This also helps steer our economy, that 110.7 million. If we can have more staff, I could say we can process more and we can make the timely processing of the client's application. There's also a reduction on customer influx of 3 eligibility centers due to the implementation of staggered SNAP benefit issuance based on Social Security number. And as you can see, during the first week of the month, usually the stores are all, it's all, there's an influx of our clients, but now there's a less influx of those clients, and we can also avail of those discounts. We receive funding increases on SNAP Ed program from 37,000 to 171,000, and then partnership with several mayors, schools, and SNAP retailers to assist in educating the community, particularly our SNAP recipients, on healthy eating with physical activity. For Bureau of Healthcare Financing, they receive and process more than 400,000 claims, and we pay out 107 million of those claims. The HIT, we also paid out providers who attested. We paid out 107,667. And then we also implemented the ACA Alternative Benefit Plan and modified adjusted gross income. And then the federal mandates for ICD-10 was also implemented at the beginning of this fiscal year, fiscal year 2016. And telemedicine for some specialty services was also implemented in FY 2016, beginning of FY 2016. For Bureau of Management Support, the increased participation of eligible households in the Child Care Assistance Program, and I will show you a graph of that later on to support this success. There's establishment of an MOU with the Department of Labor, creating a partnership in which SNAP-related work activities will be administered by DOL. There was an increase of TANF cases being closed due to employment and excess earnings in FY 2016 also. Increase of reported employment in FY 2016, timely completion of fair hearing process, and in FY 2016, the Quality Control Integrity Review response from the Food and Nutrition Service recognized Guam as one of the 11 states that provided QC data that was not biased out of the 53 states or territories nationwide. And this is an additional success for BMS. The IRO, or Investigation and Recovery Office, found 1,719 in violation cases, in violation or error, and they're currently recouping 241,043 for fiscal year 2016. For BOSA, the number of referrals and children that CPS handled in FY 2016 includes 1,389 referrals, and the children subject of the CPS referrals are 2,147. BOSA workers within the intake crisis unit continue to educate the public on child abuse neglect prevention as well as mandated reporting. As a result, there is less number of inappropriate referrals to CPS. The investigation unit received 495 referrals, and 482 referrals were investigated. Case management unit reunified 27 children with their parents, and 22 children were placed under the guardianship of their relatives. The same with other divisions, we also have challenges. One of those are workforce shortage due to lengthy hiring and recruitment process, as well as funding issue. The procurement process is also lengthy. The eligibility applications processing, timeliness, and accuracy as a result of staff shortage. Medicaid and MRP provider participation, as you know, there are limited providers. One issue also is due to untimely payment to the providers. And then Medicaid and MRP local funding shortfall. Having TANF participants comply with board requirements is also an issue, and getting them motivated to participate in training programs. Also a challenge is shortage of foster homes to place children when CPS removes them from their homes. To support the successes and challenges, I would like to show you this slide showing the full staffing of Division of Public Welfare versus the current staffing. In FY 2016, as you can see, The full staffing is 198. That staffing is since way, way back. I mean, what I'm trying to say is the total number of the clients that we do serve continually increase. But our organizational chart and our staffing does not increase. I started in Medicaid program with 4,000 Medicaid and 4,000 MIP eligibles. They are Medicaid eligible is 43,000 now, and MIP is 11,000. You can imagine the increase of those eligibles. In FY 2016, our total staffing is 132, which equates to 67% of the total staffing. And then in FY 2017, it went down to 122 or 123. There is another staff who was reinstated, which is 62% of the total staffing of DPW. As you can see, this next slide shows the applications process by our division. It fluctuates. In 2014, there is 68,000, 15, 70,000, 2016, 66,000. But you can see in this graph, the total number of new applicants continue to increase. Despite the decrease in total number of applicants for SNAP, as you can see, the total number of clients seen and interviewed by our division continue to increase. From 2014, 79,000, and in FY 2016, 100,000. This next slide shows the eligibles by ethnicity. All the eligibles going down except for FAS. They're going up. As you can see, from 10,000 to 11,292. The top three ethnic groups under the program are, of course, the Chamorro, and then the FAS and the Filipino. The total amount of benefits issued is also decreasing. It could be attributed to the unemployment rate. It's going down. I guess the economy is doing great. And it could be also due to the minimum wage increase. So from FY 2014, total SNAP issued was 113 million. And in FY 2016, went down to 106 million. Same way with the cash assistance program. The top three ethnic groups includes Chamorro, FAS, and Filipino. The decrease in the number of eligibles is probably due to economy also, as well as they're meeting their 60-month period. For cash assistance program, the the benefits issued went down from 2014 to 2016 from 4.5 to 3.8 million. The next slide shows the Medicaid and MIP eligible. As you see, I stated earlier, I started with 4,000 eligibles under Medicaid. It's now 43,000. And MIP, it's 11,000. These are the ethnic groups under the Medicaid program. Highest are the Chamorro, followed by the FAS, and then the Filipino. Total payment made by Medicaid program in fiscal year 2016 is 95. As you can see, from 2012, I think it's 47 million. 2016, 95 million. This is controlled by budget appropriation. In the MIP eligibles, by ethnicity, the highest ethnic group under MIP are the FAS. In 2016, there's 70% of them under the MIP program, followed by Chamorro, 16, and then 10 for the Filipino. Total expenditure for MIP from 2012, as you can see, it's going down because of the transfer of the MIP clients to the Medicaid program because they're now eligible there for the childless adult. We expanded the Medicaid program since 2012. So from 13 billion to 11 million in 2016. This is what I'm talking about earlier. CCDF payments and participants is continuously growing from 1.3 in 2014 to 3.5 million This assists working families with low income to care for their children. The next slide shows the number of cases of CPS. Total children subject of CPS referrals is 2,147. As you can see, it's going down from 2,321 because of the mandated reporting. In summary, DPW 2016 program participants includes more than 55,000 in SNAP, 4,000 in TANF, Medicaid or Cash Assistance Program. Medicaid is 43,000, MIP 11, and so on. It's on your copy. This shows the total now. This next slide shows the total benefits issued by each program. As you can see, SNAP is 106 million. Medicaid, MIP, and foster care is 109 million. 3.5 for Cash Assistance Program. 3.8 for Cash Assistance Program. 3.5 for CCDF. 3.8 for CCDF, and Cash Assistance Program is 3.5. There you go. In summary, the total number of unduplicated clients served by the division is 65,000, and this is 41% of the total population on Guam based in FY 2010 actual census of 159,358. And the total benefits issued is 223.5 million. As you can see, the total percentage of personnel is only 3%. 95% of those budget goes to our clients. Currently, the total benefits issued to our clients is 136.8 billion. That is as of May 11, 2017. The Division of Public Welfare goals includes continue to improve the level of services and maximize performance of staff to create greater efficiency and build the client's staff environment that promotes communication and understanding for better service. Ensure budget optimization, reduce or eliminate program penalties, better tracking of records by doing full implementation of document imaging, and then improve the timeliness of welfare application processing and tracking of data information. Also, to ensure accurate implementation of program mandates, increase the number of foster homes, comprehensive awareness on child abuse and neglect, encourage more medical providers to adopt EHR for better health care management, as well as enhance the professional skills and knowledge of staff. I'm not going to go through this anymore, but I just want to go through the last. The DPW projected FY 2018 budget based on ceiling is 71 million. 43 million is local and federal is 27.9 million. As you can see, 81% of FY 2018 budget goes to miscellaneous payment and personnel is only 9%. This does not include the 100% federally funded program. But if you're going to include that, the administration per se is only 3 to 4%. That ends my presentation. Thank you.
Thank you. Less than 2 hours. Now you.
Oh,
I tried to-
Leo's not going to do a
I
presentation.
know. I understand, but I think this gives you a better idea of what you get for your $98 million, $98.8 million. Because a lot of people really don't know the depth and breadth of the challenges that are presented. We touch the lives of every man, woman, and child on Guam. It's just that simple. Thank you, sir.
I just have a few questions, Mr. Gilman. To date, how much of the ACA money is still available until 2019?
As of 2016, we still have 151 million.
And that's available until 2019, right?
2019.
And in spite of you moving everybody over to Medicaid, we still have How much is that, 150?
151 million. We requested 34 million this year.
So that we won't fully expend that by the end of the period.
Yes, Speaker, we have not.
We will or we won't?
If there's local match, especially with the new hospital's rate, we might be able to.
If there were enough matching, Mr. Speaker, it would be spent.
As you can see in my presentation way back in 2012, from 47 million to 95 million last fiscal year. That's a great increase. If you can provide the local match, then we'll be able to pay the providers timely.
But we understand the consequences. Okay? We get used to that menu, and then the money goes away. And then the challenge is how do we keep it at that spending level? And as I said, I think we're spending on the wrong side of the dollar. We're just paying for units of care. We haven't done anything really innovative in our medical assistance programs because we don't have enough money to move around to try to do something else, pay for performance, do some things in the schools. I mean, some states have waivers where, and we talked about this before, provide safe, clean housing for homeless people, and it keeps them out of the emergency rooms, keeps them from getting drug-resistant TB, those kind of things, but we don't. So even if we were to match up so that we could spend this money by the end of 2019, the question is, what happens after that? We continue to raise people's expectations, or we continue to believe that, the money for health care is unlimited, and as we all are well aware, it's not. So what do we really need to do to get the maximum out of those dollars if we do get a match? And it's a tedious process right now to even get waivers. CMS, despite all of their good-heartedness and the amount of money that they do provide, I mean, if we didn't have them, we'd really be in trouble. If we didn't have Medicare, we didn't have people eligible for Medicare in terms of the cost of dialysis, we'd really be in a big, big problem. We might even have to make decisions like they did in Kiribati where they just don't dialyze anybody anymore. So a lot of this, the implications of what we want to do with the dollars and where they're better placed, is, I think, a subject for another round.
Which brings me to another point that I had asked you to try to prepare for. A couple of years ago, at a public hearing, the two of you blew me off the dais with the statistics where in the previous fiscal year you had paid GMH $28 million for its subsidies and for the cost of the 3Ms at the hospital. But you reported that same year you also paid $31 million to the renal centers. Or I thought that was. Do you have a breakdown of how much we're currently paying to the renal centers on island? Your mic is not on.
Oh, sorry. For fiscal year 2016, we paid 3.8 million under Medicaid, and under MIP 1.7. Medicaid total charge is 89 million. But because of Medicare paying for it, because we pay for premium of our clients, we only pay 3.8 million. And in MIP, there is 46.7 million total charge, and we only paid 1.7 million.
I think for my colleagues to hear that, it was almost $90 million was actually billed, but we only had to pay 3, and almost 47, but we paid. The local funds was 1, but that's 90 and 43. That's more than the hospital was asking for yesterday, or at least that their budget was. If memory serves me right, they said it was 136 million was their budget for the hospital. And the billing that you're getting from renal care is almost equal. And so I think the public and my colleagues have to hear this statistic, because I think Mr. Gillen's offer of trying to figure out how we can better invest preventative dollars in trying to make sure that this non-communicable disease of diabetes is addressed, because the cost is, astronomical. I know a lot of people have been wondering why my weight loss, and it was because my doctor told me in 3 months, if you don't get your blood sugar down, you're going on diabetes medication. I lost 20 pounds in 3 months. There was no way I was going to go on meds, or worse yet, putting a needle in my thigh. So we've got to get people to understand, and my diet that he put me on was a non-white diet. No rice, no bread, no sugar, no salt, no anything white. And it was difficult. But I now have a problem swallowing rice. But it's a lifestyle change. And it used to be that I was addicted to rice. If we traveled to Washington, D.C., after 3 days, I'd have to go to Chinatown just to find rice because I was getting a headache. And so we've got to figure out some way, because this astonishing cost of thankfully we have the feds to pay for it. And somebody reminded me the other day, it was President Nixon, I think, that was asked if, or maybe, I think it was President Nixon, but it was a Republican president that was asked if someone doesn't have the ability, who asked if someone doesn't have the ability to pay for dialysis, which at the time was $3,000 a year. That's like one visit or 2 visits now. What happens to them? And he says he was told they die. And so he signed the executive order that has the federal government picking up 95% of the cost. But as an island, we cannot afford it. And if the federal dollars, as you put it, don't come in, if we're only paying $5 million now and the cost is 136, we're drowned. We would have. There would be no way that we'd be able to address that. So over the next couple of weeks, we're going to have to sit down and try to figure out with Department of Education how we can get that. I've been talking to them about PE for the last 8 years. And but we've got to get the kids moving. And we've got to get people to understand that as bad as it sounds, we've got to do something about our sugar and our white stuff intake, because it's going to take us down. So I'm hoping that offline, between as many of your people and my staff as possible, we can try to figure out something with DOE to try to. I noted that for my colleagues, Public Health and Social Services is the largest line agency, because DOE is not technically a line agency. But the amount of money that's withheld from you in your, whatever they call the set aside, maybe some money there. We can try to figure out how to get to DOE and do something about this scourge, really, because it really is and the cost, now that everybody hears it, this is more scary than the last time. When you tell me that that's the total billing. I have no more questions if anybody else wants.
Mr. Speaker, that's just one disease. And we start talking about, and a lot of these are preventable. Okay, so we need to talk about some cancers, and we talk about stroke, hypertension, and things that happen with the disabilities that come with that, and the costs associated with that we haven't figured into this. And it really is, disappointing to say that despite all of the work and hard work that these people are doing, our people are not getting better. And the only hope is that cohort at the very end of that line, our kids, okay, who do not yet have risk. Okay, we have to do some palliative things with the rest of the people, but our children really are where it's going to pay. And a lot of you, won't be here if we see the success. You'll be, doing other things. And I know that as people who want to get reelected, your horizon is 2 years, and then you work on even less than 2 years to work on being reelected. So the commitment to make this a sustainable sea change in how we deal with these types of diseases, because apparently the medical model is not the answer. I mean, we know that we need supplies and we need equipment, and we need to do the kind of life-saving things that everybody gets involved with emotionally. But we don't make some changes in how our children eat, what their attitudes are about sugar and the white stuff, and that taro actually is better for you than rice in the same amounts because it's not as calorie dense. All of these kind of things. We really have to start selling to our children. So, and that's a long. You need a lot of stomach, and a lot of us won't see it, but we have to start the work.
And I want to thank you for quietly dealing with me, calling you about HPV and cervical cancer. I read Dr. Haddock's epidemiological report every week, and to see 2 cases, 1 case, it's on a weekly basis, and if we could just have everybody understand the importance of the vaccination, and the fact that it's covered in our health insurance and it's covered in your MIP and Medicare payments for the indigent, we really should be able to get our entire younger generation vaccinated so that cervical cancer doesn't have to affect so many of our women and the attendant problems that the men have, which nobody seems to want to talk about. But it's real. And the number of young people that are having throat cancers and young men, it's frightening. So we've got to address that, and I want to thank you for putting up with my emails and asking if there's ways that you can find the money to vaccinate children. But we've got to get out there and be more aggressive about that, because that is, and thank you for acknowledging the work that policy changes that we've done in other areas, but some of this just really has to be done. And now that I'm hoping that my colleagues will join me in some of the things in the future about trying to address this, I'll let some of them ask questions.
Mr. Speaker, if I may. With regards to, we've discussed many times, and thank you for coming out about the value of prevention. I know there have been initiatives with salt intake, addressing many, the full scope of NCDs. Is there been much initiative, especially in the school system, with HFCS, high fructose corn syrup, things like that, sodas, sugary drinks, sugary treats, and just how prevalent it is in the food that we eat, the processed foods that we eat, and how it affects individuals in the long term?
I think the schools have taken the vending machine, at least the sugary drinks out of the vending machines. But
Senator Rodriguez's bill too.
right? I think so. Yeah, right. They've taken it out. Some government agencies, we're supposed to have that, that initiative, and I know in public health we don't have any at all. But I think some places, if you've got it like a food cart outside your government building, they can still have, because we didn't address those. So I just kicked them off the property. But I mean, other people don't have the will to do that, and it's the will to do it. Okay, but we're also talking about, there was one Pacific Island country that actually just banned sugar-added beverages. Okay, knew it. Okay, but they only have like 3 people living there now. But I mean, no, but really, they did it. And that cost jobs. Okay, and when some of these policy changes cost jobs, when we talk to DOE about the school nutrition program, I don't know what they do about high fructose sugar.
I don't necessarily mean the school nutrition program. I think just maybe looking at the potential of a campaign to educate students on, when they educate on nutrition, because most people don't realize how prevalent high fructose corn syrup is in almost everything that we eat nowadays. And yeah, I still keep up to date with the American Heart Association and the different studies that they do attributing strokes and heart disease, even in healthy individuals, with just high fructose corn syrup, which accumulates in the arteries and blood vessels. And I think, as to the initiatives that we want to do in terms of preventative care, not just with diabetes and how it's all related within the body, I think that'd be one that we can look into, and I think a lot of my colleagues would potentially support that in terms of building a healthier future for not just the adults, the elderly, but also the children, because those habits reciprocate. And then the cost of that education campaign over time will dissipate as well. So I think it'd be a great investment both in the health of the population and fiscally for the island. But again, thank you for being here, and I'm sure we could talk more. I'm always open for dialogue.
Yeah, I think some of these initiatives, Senator, do like I said, you need stamina, because it's going to take a while to show the payoff. But the buzzword usually is evidence-based and science, and there are approaches. I mean, we've taken in some eating establishments, the salt is off the table, and all of those soy sauce and all of that, and you have to ask for it. And sometimes people get used to not having it. So the payoff is down the line somewhere. But if we don't put some rigorous approaches, and I know the challenge that DOE has, just from what I read, but that you have only so many teaching hours in a day. So how much time are you going to spend on nutrition? How much time are you going to spend on physical education, which I think they all spend a lot of time on, because kids need to run and play, and they need to do those kind of things. And, community gardens in the schools, and showing them how, from planting to growing to putting it into their lunch, to see what the value of that is. Now, we've tried some of those, but I don't think, again, we sustained it long enough. And DOE has the challenges, again, with the union contracts and everything else. How many hours do they have? But they have the children for, 7 hours a day? What better place to, if I were a Maoist, I guess, to indoctrinate, people. When you have your children coming home saying, Dad, why are you putting so much salt on your, Dad, why are you drinking, those kind of things. Then we know we're making some headway when your children now are the food police, okay? And it's not the Department of Public Health and Social Services. So, but it's going to take a while.
Thank you, Mr. Chairman, and thank you very much to Jim and to all of your staff for being here and for the work that you guys do. About 2 years ago, we invested about $1 million into the Getting Guam Healthy program. 300,000 of that, I believe, was for DOE. And I know that there was some initial challenges in getting that going, right? Just the funding and everything. But I know it's happening now, right? And they're starting to get programs moving. But one thing I would like to do is working with the chairman is not taking from what you already have here, because we know that you're working under a ceiling here, which is not something you would want. But maybe working with the chairman and looking at ways that we can invest more into this Getting Guam Healthy program, because that's everything you've talked about on what we need to do. We're not going to see the results today, tomorrow, next year, 2 years. It's gonna be something down the road. But in the little that has transpired already, we know that investing into this program will be able to help our community become healthier, so that we can avoid the 95 million expense and a big chunk of that goes to renal services. So these are some of the stuff that we need to look at, Mr. Chairman. I know the law right now specifically says that money, that $1 million, is used for Medicaid beneficiaries. I know that's one of the challenges. We need to open it up and perhaps get it to more of our MIP. So that's something we'll work on. That's a commitment you have from me that we'll work with the chairman. Right now, the iFit program, I think that the Guam Cancer Care is doing over at public schools. I know for a fact because my son, he loves it. I think it's twice a week that they come out, and we need to expand that. And we can work with nonprofits to make it happen. They're working with DOE, so that we really can get our best bang for our buck. And that's something that we will explore even further. But I just wanted to get on a record. I also want to thank the community health centers, Linda, who the outreaches that they do. That's where we're making strides, I believe, is that when they go out there and immunize our kids, that's where we can start these preventions, and they're doing more of that now. So we've got to continue supporting them on that, and thank them for even coming out with our outreaches when we do it. Thank you.
Yeah, and I think to that, Senator, your point's well taken about outreach. And when we talk about making these really significant changes to where we put the dollars, we need to start talking also about the kinds of people who are delivering the health care. A lot of times we get stuck in these conventions that, only a registered nurse can do X, and only an LPN can do X under the supervision of a registered nurse. And if we're doing immunizations, if we want to have immunization on demand, and people come in to public health and just say, I need to get an immunization, we shouldn't be waiting to see if there's an RN available or an LPN. I know how to do that. Okay, a lot of people know how to do an intramuscular injection. So if we can start breaking out some of these restrictions, community health workers, we talked about that before, this different kind of provider of health information and health care. And we really do have to look at where we're going to, take the time and effort, because those outreaches are effective. Okay, we probably would have never immunized any of those people if you hadn't gone out there with them. Okay, or if Linda and her people hadn't spent the time and effort to do that. And the community health center is a very good concept when it's in the community, and but when it's kind of reactive, like a lot of us are, we wait till people come to us, so the care is episodic, it's not continuous, we have problems. So, there's a lot of things that need to be changed, and I'd like to get started on those before I go away, so that, that there's an understanding that nurses, doctors, physician assistants, all those people do great work, but we don't have enough of them, and we've got to figure out a way to get help. You get a well-trained medic, and a medic can do a whole bunch of stuff in the field, I'll tell you. And if we can get people to train up to do certain things, they can be limited, but still, make use of people who don't need a BSN and a MBS and all, I mean, really, it's getting to the point here where we're not only dollar challenged, we're human resource challenged. And we need to find another way to provide health care.
Thank you, Mr. Gillen. Thank you all for coming and for your presentation today. I have a couple of questions. Maybe I'll start out with the needs that I want to address for Child Protective Services. And so I wanted to see if I could have Ms. Linda Rodriguez or staff available as a resource for these questions. Is there somebody here who can help to answer that? Thank you. Thank you so much. It's my understanding from meeting with you and Mr. Gillen at the start of the term and in subsequent communications and even today, today's presentation by Ms. Archangel, that you're in need of additional social workers. Is that correct?
Oh, yes, that is correct.
Is it correct that you should have 5 additional social workers to conduct custody and adoption studies and look into child abuse and neglect referrals?
Yes. Actually, we really don't need the custody studies, though, because that unit is pretty much filled. But as far as our investigation unit is concerned, we normally have 8 investigators, and right now we just have 5. We lost a couple of staff last year, and then about 3 this year. So all social workers.
Thank you. In FY 2016, CPS received 1,389 referrals on child abuse and neglect. And right now, for fiscal year 2017, from October 16th to this month, you've already received 1,042 referrals with fewer social workers on staff to handle the increasing referrals and caseloads. Is that correct?
Yes, that is correct.
Is it true that CPS is currently in the red and that the 5 social worker vacancies you are unable to fill is because you don't have the funds available?
Right, that's because our funding has not all come in, and that's basically why we haven't been able to recruit.
Thank you. These social worker positions at CPS are funded federally, correct?
Yes, all our positions are federally funded.
So we have not relied on local funds for the salaries and benefits of social workers for CPS for at least the last decade. Is that correct?
Yes, that is correct.
But today, you're running in the red for the CPS budget on the social workers you currently have, and you're unable to hire vacant positions. Is that correct?
Yes, that's correct.
It's clear that there's a gap in your budget for local funds to hire and recruit the required social workers to do the work that we need to do to protect our island's children. Is that correct? There's a gap in the budget.
Yes, Senator.
So I have an update from you, Ms. Rodriguez, about CPS needing between $120,000 and $180,000 for 2 to 3 social workers. So if we were to work with the Appropriations Committee, with the chair, to secure some of that funding in FY18 budget, would that help us to meet our commitment to protect our island's children through CPS?
Yes, that's correct.
May I interject?
Sure.
This funding is federal funding, and it comes in allotments.
Yes.
Now, if you want to prepay the allotment, and we can reimburse somehow, but that's always been a problem with federal funding, is the timing of the allotments. Okay? So I'd be happy to get a bridge loan. I know nobody likes to talk about loans, but if we can find a way to do that and then reimburse the federal account. But that, we've talked about this with HHS and a lot of these partner agencies about how the money comes out. Even Arthur's program has the same problem. The allotment doesn't come on a timely basis, so we're kind of stuck because we can't certify the funds available. And of course the recruitment process. And you know, we're graduating social workers out of UOG, and I want to get them in,
Right.
because you know, I don't want them to get frustrated and go look somewhere else. So if you can help us with that.
Well, as you know, Dr. Gillen, I'm certainly committed to trying to figure out the best way forward in this. I know that the chair has expressed his commitment, so we're just trying to work through the numbers that you've presented with us with and see what we can do to make sure that we address this concern. My concern is also with the current fiscal year, so perhaps Dr. Gillen and I can raise with the governor's team about perhaps detailing social workers or utilizing the governor's transfer authority to assist us in this situation. So maybe that's another avenue that we can work with to try to address this situation. We know that April last month was National Child Abuse Prevention Month. I feel very strongly that we need to find the local funding or resources to get CPS social workers at the Bureau of Social Services Administration, BOSA. So I'll be in contact as we work to find a solution, and I want to thank the chairman for his dedication. I want to thank you all so much and your hardworking staff for the heart-wrenching work that you do day in and day out. I know this is definitely a priority for me, and I want to thank you so much for all the work that you do. So thank you, Ms. Rodriguez. Thank you, Dr. Gillen, for your work. I have a couple other questions for you. Mr. Gillen, regarding the law for medicinal cannabis, is there any legal impediment to your department implementing that statute?
I do not believe so.
Okay. Have you made accommodations in the FY18 budget to establish and start implementing the medicinal cannabis program?
We are still using the $100,000 appropriation from the Healthy Futures Fund, which I believe carries over.
And that was an appropriation from FY17, correct?
That's correct. 20, whatever the law was.
I have a few more questions, Mr. Chair, but I'll allow other colleagues to ask their questions, and if we have time, I can come back to mine. Thank you. Thank you very much.
You're welcome.
Thank you, Mr. Chair. Good afternoon. It was pointed out earlier that information technology support is not readily available, but it also notes here that you're working closely with the Office of Technology. Public Health has a dedicated IT team, or, okay, so you're working with OTEC. So OTEC's handling all your IT initiatives.
Yes.
So when you're pointing out not readily available, is it really response? Okay.
I think things at the center have gotten much better since we came in. And as they get more staff in that has more IT savvy, and it's taken a while to build that up, because again, the people who do those kind of things, are pretty expensive, and to get that kind of expertise and to keep them here, working on a daily basis is, Hawaii has a whole department that just deals with those kind of things, and it's, things look much better than they have been lately, and I think upgrades to a lot of the providers that are now, you see digging little trenches in the road now, putting their their fiber cable stuff in. I think the systems get better as we get better equipment, more reliable equipment, and I have noticed a big difference between 2011 and now, so it is getting better.
I just asked those questions leading up. We'll be meeting with OTEC very soon, and it's good to hear these concerns, so we could raise them. I know they have developed a roadmap going forward on how they would address a lot of the challenges, particularly in the line agencies. So I'm just curious to see the type of budget. I know it's built into the Department of Administration, but I would like to see, based on that roadmap, that we should see incremental increases to support the line agencies' needs or IT needs. So I just raised that concern.
Well, I think too, Senator, that Tess was talking about the incentives that we've given to several providers to develop their EHRs, and including the hospital, okay, their electronic health records. What we really need to do also is get this interoperability, because a lot of doctors have different record systems. So if they're going to give us information, we need the interface for each one of them. The community health centers have a good system now, but they're not able to talk to too many people except us because they can't do that interface. We wanted to ideally have the hospital also share with us their EHR records for disease surveillance. Okay, they'd be the first point of contact and then we would know about it right away, rather than having to go over there and look at their charts, or somebody call us up 2 days later before we find out we've got an infectious disease case. So we're hoping that all of that gets built so that all of the systems can talk to one another. That when a child gets immunized at Dr. X's clinic, my web immunization system is automatically populated so that we know accurately what the immunization rate. I promised Senator Rodriguez, I think, on at my confirmation hearing, that we would get the immunization rate back up to 98%, where it was when I first started working in public health. And I can't tell you today what it is because the system is not working very well. So, and it's not cheap. Okay, so if we want information, we want good information and fast, it's going to cost.
No, I appreciate that
And you
thought
know that.
process, because we were talking the other day, and just with the fiscal team or BBMR, and when a transaction occurs at Revenue Tax or at the Treasury, that the entire those responsible from DOA, BBMR, Revenue Tax, would see the number in real time. So I appreciate that thinking. I know we were talking earlier a little bit about the type of diets in our community, and I know these are federal programs, and I commend you for your efforts in the processing of our people that really need the support. And you also mentioned that if you have more people, or you could process more. I was looking at the challenges here under HR. I'm not sure if these are the positions you're recruiting for, or is it? I know you have. It's really, but it's. And I know, Director, you pointed out there's some delay, but are these the positions you're talking about? If you had more folks, are these are in process right now?
Where we're really lacking is the eligibility determination part. And one of the reasons we're not getting a lot of recruitment there, and this one, DOA has been very good about getting us listings. People don't want the job. One, because it doesn't pay very much, and two, the caseloads that they have to handle are very high. So we have a request into DOA to consider redoing that whole job description and giving an increase in pay. When you get a nutrition assistant in the WIC program, nutrition assistant, making more money than an eligibility worker, entry level, who makes multiple decisions as they're processing, it's just a little out of whack. And that was one of the problems with people not inputting effectively into the Hay Plan study, which took a lot of people's time, and some people didn't want to do the work, so some people were shorted. So we're trying to, it's not just a matter of how long it takes to get recruitment done. It's people don't take the job. We had a list of I don't know how many, and they all turn it down.
This SNAP program, I kind of understand a little bit, but the WIC program, I know my sister was there at one point, and she educated me a little bit about it. But what I really liked about the program is how it's specific to what, I know we're dealing with children and what type of foods that could be purchased. But I'm not sure if it's been discussed at that type of program has been trying to be bridged with the SNAP program. We talked about the foods we buy or the type of things we consume, but has discussions been put in play regarding SNAP play at the federal level of how we can control the types of foods that are purchased in our community using the SNAP program? We have an advantage here of that could be happening because we have 55,000 people, right? And we can have a major impact if we can help control the type of, I know it's sensitive to talk about, but we have to talk about it.
No, we cannot control the type of food that they do.
I understand this, I know
But
right now, but
there's
no discussion
no
about,
discussion at this
because
point.
there's a WIC program, right? And we understand what it's designed for, and I'm just wondering why it just can't, maybe I'm just thinking too common sense here, but do I make sense though?
It's the same federal agency, right? The Food and Nutrition Service. The WIC program is 100%, and it puts another about $9 million into the economy in terms of the vouchers. But they also have, a cadre of people who, as you know, spend the time educating the clients, showing them how to make wise choices and budgeting, preparing meals, and those kind of things. But that administrative cost is very high. Now, if we would try to match that up with the SNAP program that's paying out $103 million or $110 million and try to duplicate that, we're doing it a little bit with the SNAP Ed program, but that's only like $134,000 on $103 million worth of food benefits. There are a lot of changes, and you know that the administration in Washington has made a lot of noise about making some changes, but only mostly like you got to work for your benefit rather than let's help people make healthy choices. Because there are too many people, I'm sorry, and I'll say it, I'm so far away from Mr. Trump I don't have to worry. The food industry, okay, and the agriculture industry, has a big say in the food stamp program. Billions of dollars. You really think they want to change the way things are? I mean, we have one side of the FNS house telling us, you know what, you're not even enrolling the numbers of people. We're estimating you only enrolled 70% of the people who are potentially eligible. And then on the other side of it, they say, you're not enrolling them enough, so we're penalizing you for being so slow. But then when we say to them, well, the problem we're having is, I'll get a report from Payless or from some other market and say, this lady just came in today and bought 2 cases of 10-pound coffee, and can't we do anything about it? And the FNS people say, nope. Once they get it, they can throw it in the ocean for all they care. So there are a lot of other players that are involved in this that we have no control over. And I don't know, and you're right, people are not making wise choices. Now, what we can try to do, again, this is another policy thing and another thing that, I think we need to get the food establishments involved in, is how do we make the healthy foods a cheaper choice? Okay, how do we make the high-salt foods more expensive? And there's a double-edged sword because they've tried that in some of the South Pacific countries where things like the ox and palm corned beef is now a staple, so that if you tax that to excess, they can't eat because they don't have, they've lost the ability to even grow their own stuff. So, we really, it's really disappointing sometimes to see that to me, I've always told you, as long as a child goes to bed not hungry, I'll put up with a lot of the nonsense. But when overall they're making not very informed decisions about what they buy, and they have to try to spread. We're not giving people, hundreds of thousands of dollars to buy food. Okay? They're getting enough to get by, and it's these stories about people, just stacking up ribeye steaks and cases of this and that. That might happen, but not all the time. Most people are really just trying to buy as much as they can to stretch. And I know the last few days of the month have been always a difficult time for people because they just couldn't figure out how to stretch it. So we need to do some more of the WIC-like kinds of things, but where are we going to find the money to do that again? It's another one of those challenges. But if we can find a way to make, I mean, talked about this. If you go to Payless and you want to support local, buy local. But if a pound of bananas costs $1 more than the Chiquita bananas that come from I don't know where, it's very hard for the person who's trying to stretch their budget to not make the choice for the cheaper buy. So what do we need to do? Not only with local grown more healthy because it's fresher, but even like I say, all of the processed food that's out there that's still cheaper than whole grain bread, and, all of these things, okay? White rice is, even if you don't eat that anymore, Senator, it's not even enriched. If you're going to eat it, at least let's have some vitamins in it. So, I mean, we can spend a whole lot of time on how to try to fix that. I just don't know how to do the high math to change. Again, at one time I talked to somebody about saying, okay, we'll charge $3 more for a loaf of white bread, and then we'll let the retailer keep $1 of that and take the rest of it and put it into subsidizing and lowering the cost of fresh vegetables. But I need somebody else to help me with that math. But I don't know. But that goes hand in hand with preventable, you're going to prevent these diseases. This is part of the healthy choices. You make a good point, Senator. WIC program is an ideal, but the administrative expense to match that in SNAP with that number of people, pretty expensive.
Thank you, Mr. Chair. Thank you, everyone, for coming out today. I promise I won't take too long. I just have two questions. One is in reference to the Catholic Social Services. I understand that there's sometimes they have a payless payday. Is there a contract that we, I guess we could talk a little bit about it, but.
Yes, we do have several contracts, actually several programs on contract with Catholic Social Service.
So is there, what is hindering the agency paying Catholic Social Services on time? What is the challenge?
Well, we're going to have to say cash flow because that's really what it is.
Okay. And then one more question. Ms. Archangel, you presented, I was speaking with hers, and the number was extremely shocking. In FY 2016, you presented about 41 of the total population of Guam, 41% of the total population of Guam was receiving some form of welfare. Is that true?
Yes.
Do we do anything, is there anything that we can do to take these dollars and then turn it into jobs or some kind of program that we can do to help these people so that we don't have to continually give assistance, but we're empowering them to provide for themselves?
Yes, we do. We have the jobs program and the SNAP employment and training program. But for SNAP, they're not mandated to participate in that program because we have the ABAT waiver, which will actually end this fiscal year.
I see. Okay. Thank you, Mr. Chair. I'd like to meet with you guys to speak a little bit more in depth about this and maybe, figure out if we can do something a little bit more long-term and concrete to decrease the number. I know you're doing all that you can, and thank you for your hard work. I know it's not easy what you do, so thank you very much for giving your time and your sacrificing for our community. Thank you.
I sound like a broken record on this because I say it almost all the time. These jobs programs, have very little success. The numbers are small, people that actually get off the program and get a job. Part of that has to do with the wage that they earn. If the benefit that you get from being in the assistance programs is better than the salary you're going to get at the job that you've trained for, why bother training for it? Okay, and we've looked at that. I mean, if you take just a family of two, and the one is a worker and makes $15 an hour, they still could qualify for some of our programs because $30,000 doesn't get you far.
So we have to help them,
we have to figure out a
educate them and change the mindset, the mentality.
Figure out a way, again, among all of us, because it's not just public health and all
Right,
of the people here. How, in a sense, okay, if you train up for a job, okay, and the job pays $10 an hour, but the dollar per hour value of your benefit is 15, maybe we got to figure out a way to let them have the 5 until they move up somehow.
Okay, thank you.
Something
Yes.
like that.
Thank you, Dr. Gillen. Thank you for that.
Stop promoting me. I'm a mister.
All right, that's
Thank you.
perfect. Fantastic.
Thank you, ma'am.
Thank you.
Sorry, 2 quick questions. I had a question about environmental health, but it was answered. Thank you for your very thorough testimony. It was about food safety, but you answered it. Real quickly on, let me know what this is, Division of Public Health. In the PowerPoint presentation, I'm looking at page 8 on successes. You're talking about telemedicine with Good Samaritan Hospital, and there are bullets on the bottom that said since 2016, 19 patients have been seen, and there are currently 64 patients waiting to be seen. What's the problem? I mean, why do we have so many waiting? Is there like a scheduling conflict, or what's taking? Okay,
We'll
thank
have
you.
Linda DeNorsi answer that.
I mean, it's great that they no longer have to travel off island, that we are working to make telephone contacts, but
No, the issue we had was our nurse practitioner had to go on maternity leave for 3 months, so she's returned. And we just met with Dr. Quiros, the cardiologist from Good Sam, that is overall the project coordinator with us. And we are just making arrangements between their dermatologists and our providers so that we can determine how many patients we can schedule, because we have to make certain that the hours are very much coincident. We're in a different time zone. That's one of the issues. So we're trying to work out how many providers or how many doctors we can have to do telemedicine. We just recruited 2 new family practitioners. So what we're trying to do is we're trying to get one of them to be a backup for the other provider, so that should she go on a maternity leave again, which I hope she doesn't, precautionary measures will help. So at any rate, when we do that, we're able to plan way ahead of time. That's why it's called family planning, right? Okay. So we plan ahead of time. We make certain that on the other side, they have enough time to devote and tell us, well, we have to ask our provider that's there, do you have enough patients, number 1? Number 2, is there enough for the other side, which is the dermatologist or the rheumatologist, to have enough time to accommodate that time frame. So we're looking at 60 minutes at the most, sometimes 30 minutes, depending upon if it's a follow-up visit or it's initial visit. Usually initial visits take a lot longer because a lot of prep work has to come in place. Sometimes they have to use the dermoscope, they have to use specific telemedicine cart equipment to get snapshots to send them. So that's what we discussed just recently with Dr. Quiros, and so we're just straightening up the scheduling at this point in time. But we're not going to let them wait any longer. We're definitely going to address this issue, and so it's just a matter of scheduling.
that's helpful. Thank you so much.
Sure.
Last question. On the WIC program, I think it's page 17 on our PowerPoint. So one of the challenges that was indicated, the WIC program has inadequate facilities to service its caseload. The WIC Mangilau Clinic has been uninhabitable since the end of FY 2016. And then the overall WIC caseload has fallen from an average of 7,200 clients in FY 2016 to approximately 6,600 clients presently. Can anybody tell me why the decrease? I'm sure it's a number of things, but if
Okay,
you
you
can
know,
identify.
the facility in Central was actually a temporary wooden building, right? And so now it comes to a point where it's unsafe for them to be in there. So the staff relocated to the Tizen office, right, which is really small. It actually can't accommodate all that staff and everything. But they also found out that a lot of the patients don't want to go to Tizen. They were comfortable with Central, right? So they don't want to make that trip to Tizen.
So that's the reason why the caseload
Right. So
decreased.
also they also lost a lot of staff through resignation or retirement. So they've been having a problem recruiting the nutrition assistants as well. So it's a lack of staff. The people also don't want to go to the Tizen location. So we're trying to find another location for them to be in Central. So that's the reason why it's been decreasing. So it's the shortage of staff plus the location they had to move to.
Okay, thank you. And thank you, Mr. Chair.
I know that sounds a little,
Tizen is the middle.
no. It sounds a little strange to me, you know, that you would drop off that much, you know, if there's another facility, but if it doesn't accommodate the numbers, what we're going to try to do is we were talking about, we have a, you know, a 16-chair dental facility that is not fully up to, and we were thinking about converting that space for that. It's in more solid, obviously a solid building. So hopefully we can do that, or we'll maybe try some extra outreach to see if we can get those people back. I can't imagine why they wouldn't want to come somewhere to continue their benefit. It's really a strange, that's an anomaly. It's really, and I haven't figured out what that
It
is.
just seems like a really big drop off
Yeah, absolutely.
in 1 year.
But it also may be that, you know, if we do, we can ask Charlie, who's not with us, but just to do an analysis of why that is. It can't just be that the building is closed.
Well, thanks for hanging in with us in this long hearing. Thank you, everybody.
Just one last question, Jim. Yesterday there was mention of the Medicare reimbursement and rate and the possibility of a state plan amendment. Do you want to discuss the ramifications of a state plan being, what additional funds you might need if?
Senator, are you talking about the payment methodology? Is it about the payment methodology to amend the state plan? Basically, Medicaid pays based on the upper payment limit, and the upper payment limit is Medicare. So as far as hospital GMH is concerned, they're already at the upper payment limit, which is 1,123. So if we're going to change the state plan, it's still based on their cost report. It's always based on the cost report. And the cost report that they're providing Medicare probably will not have much of a difference on the cost report of Medicaid. But we could try if they want the Medicaid interim reimbursement rate, but what CMS is asking is what will be the difference. It might decrease or it might increase. But it's still based on the cost report, how much they're spending to provide the service.
It wouldn't require the convening of the state planning agency to completely redo a state plan.
Can you repeat that, Senator?
Would it require the convening of the state planning agency to amend the state plan?
No, Senator. We can drop the state plan, depends on how the methodology is, but it has to be reviewed by CMS Central Office in Baltimore. So it's up to them, but the bottom line is it's based on the hospital's cost report.
Well, it's almost 5 o'clock. And so I want to thank you for your presentations. I'm sure you helped educate my colleagues about all of the hard work that all of you do, and I'm glad I have a new advocate to talk to BASA about the need to take care of my children at CPS. But we've got to figure out something there. Thank you all for all that you do, and we will recess this hearing until tomorrow, until Wednesday, 31st of May, when we meet with the Guam Police Department. So we stand in recess. We stand in recess for the budget hearings, because we have session next week, until the 31st of May, when we meet with Guam Police Department. Thank you very much.